So, good morning, ladies and gentlemen. Let's start with our next session, Free Papers session, and it's my great pleasure to introduce the first speaker, Jörg Pauls from Germany. He will talk about the real-time AI in robotic surgery.
Yes, thank you very much for the introduction. I'm going to talk about a difficult topic, hopefully in a very simple way. I worked together with my good colleague Ghulam Abbas from South Africa and developed an algorithm and an AI model to look at the training possibilities in terms of robotic surgical gesture recognition. I have no disclosures or conflict of interest. You guys all know that robotic surgery or minimally invasive surgery generates rich data streams in terms of videos, in terms of kinematic data, and that is of course ideal to develop a model or an AI model to look at surgical training, to look at surgical gestures, and gestures are basically the steps of a movement during surgery. For example, needle passing, for example, knotting, just movement of instruments, and those gestures or surgemes, like it is called in AI and in modeling, are the segmentation of those movements, and that is ideal to make an AI model. So that's what we did. So we looked at the jigsaw data. That's the gesture and skill working assessment data set, and that's freely available and also published. And we looked at suturing and built a model to see whether AI model can learn how to look at suturing, because it's a perfectly repeatable task and good to look and to learn from in an AI model. We used a long short-term memory neural network, which is basically a specific AI model that can learn from itself, and that I'll explain with a few tables. As you can see, this is the overflow of the data we used. So the database, of course, the jigsaws, that's something you can look at online. We took the suturing aspects of one novice surgeon, so all consultants, but a novice robotic surgeon versus an expert surgeon. And if you segment those suturing gestures, we had 4,301 intended frames, and one of those frames has a length which is 30. It's basically if you take a picture and you take 5 pictures after one, that's the total movement. That's how an AI model learns and looks at the data. They all were done with the Da Vinci surgical system. And as you can see, that was our first hurdle, is that not every gesture is in the same amount in the model. So that can possibly give an imbalance, because your model needs to learn from all the gestures. This is our accuracy graph, and you see on the right side you see a blue and an orange line. When you make a model, you look at its accuracy, and then you use it to train itself. That's called epochs. Might be a bit difficult to explain, but in the end, after the internal validation and the training epoch, the accuracy is almost 89%, which indicates that this model learns to recognize suture movements, suture gestures. And our philosophy is that this is an internal validation study, because we use data that's freely available, and then the next step is to externally validate this. For example, if you do prospectively and ask people to hand in their robotic surgical data, which can be done with the help of course, Medtronic or Intuitive, etc. Discussion points. These data, it's retrospectively generated data which is published, so everyone can do these experiments. Everyone can look at what we did and try to reproduce it. Like I already said, internal versus external validation. We made a model based on data that's already there, and ideally you need to validate this model on prospective data and also on different surgical systems. This was done with Da Vinci, but also Hugo and other robotic systems you can use this for. And then the next step is, what can we do to integrate this model in surgical training? Ideally, you want an AI model that looks at your movements, that can judge whether you do something good or wrong. And so probably in the next few years, we are going to integrate this in simulation training, like it's already present. And of course, what we can do prospectively is compare this with normal structured assessments, like for example the OSATs versus an AI model. This is my colleague who helped me work and develop this model. The guy's everywhere in terms of AI research and won, I don't know, 4 or 5 prizes last year, so this is the one to watch. That's it. Any questions?
Thank you for this very nice presentation. Are there any questions from the floor?
Yeah, please.
Yeah.
Use it for plain laparoscopy, not robotic.
Yeah, it's
Not that many data.
yeah, the problem is the segmentation. It's basically because certain instrument handling in laparoscopy is more dynamic because you have more ways to do it, and the robotic surgical system is more staccato data. So which basically, if you move your arm, you can do it in a certain direction, and laparoscopy is more difficult. But in the end, the model will get more complex, but you can also do it with laparoscopy data.
Yes.
Jaco, congratulations for this wonderful presentation. So what's the next step of your study? What's the next step?
The next step is we did this for suturing, we did this for knot tying, and for basic movements. So how much you move your instrument in a space or in the abdomen. Then the next step is a prospective study, in which we will ask every robotic surgeon to hand in their kinematic data. The problem is, and that's something I already discussed with the guys from Intuitive, it can be very difficult to get these kinematic data out of the system, and large amounts of data. So to do this multi-center, we need to make a good protocol how we share the data, because then we're talking about terabytes of data, not gigabytes, terabytes, and that can be difficult.
Okay, thank you. Any other questions? So thank you, and we'll move on to the next speaker.
Yes. Is prediction of weight loss and resolution of obesity associated disease after metabolic bariatric surgery using machine learning with the UK National Metabolic Bariatric Surgery Register?
Good morning, everyone. I'm Shiv Banderi. I'm a senior upper GI resident from the UK, and I'm presenting my work in collaboration with the British Obesity and Metabolic Specialist Society on predicting weight loss and metabolic outcomes after bariatric surgery using machine learning on the UK National Bariatric Surgery Registry. Today I'll walk you through how we built our predictive model and what we found. I've no disclosures, but I'd like to acknowledge Dendrite, who were quite important in making sure that we obtain the registry data with good governance, de-identified and anonymized, and they helped with some of the data cleaning, which in the early stage was quite difficult. Outcomes from bariatric surgery vary widely between patients. In clinical practice, multidisciplinary decisions regarding whether to offer surgery and what type of surgery rely heavily on experience and pattern recognition. Some of you may know of the Sophia tool, which used AI and machine learning to try and predict weight loss and metabolic outcomes across quite a wide European cohort, but that cohort didn't really include the United Kingdom. And in the British NHS, the population is quite different from those because in terms of patient selection, access to surgery, and partially probably because of treatment goals. So there's a growing interest in using AI to predict outcomes in surgery, and there's an opportunity to explore machine learning in the British space regarding this. So the National Bariatric Surgery Registry captures data on both NHS state-funded and private bariatric procedures in the UK. It's expected, but not mandated, that all bariatric operations are entered into this registry, but it does form the basis of national annual reporting. And adoption across British bariatric units is actually fairly reasonable, which makes it a good real-world data set to evaluate outcome prediction at a reasonable scale. So what's machine learning? I'm quite time constrained, it's quite complex, but essentially machine learning allows computers to learn patterns from data and make predictions without really being explicitly programmed on how to do so. And in healthcare, this has got wide implications in terms of prediction, decision making, but today we'll focus on prediction. So the model I used was XGBoost, extreme gradient boosting. There are other models. XGBoost is one of the most popular, it's one of the most easiest to use, and is already quite widely reported in the healthcare literature specifically. But it basically works by making a decision tree, finding out what its error is, making a new decision tree, and improving iteratively and iteratively. And we can control with some parameters how it goes about that. So the aim of the study was to assess the performance of such a model to predict percent excess weight loss, which is on an idealized BMI of 25, type 2 diabetes resolution, and resolution of obstructive sleep apnea, trained on data from the National Bariatric Surgery Registry. So we took the registry entries between 2018 and 2023 to try and capture a contemporary era of bariatric practice and avoid the time period where the National Registry was just being started and was in its infancy. We used primary operations only, excluding any endoscopy or revisions, and we took follow-up data from the closest entry in the registry to 12 months within a 9 to 15 month window, and we excluded any duplicates or those where there was no operative or follow-up data. And then we screened it for erroneous values because there were some entries in the registry, with BMI values of 3, which needed to be excluded as erroneous, and then reproduced the BMI calculations directly rather than those that were entered in the registry. And we did it through R to run the machine learning. So some technical aspects of the model, just important for reporting. 80% of the data was used to train it, 20% to test it. It was validated across a 5-fold cross method, and we stopped the model early. Once it was no longer really improving itself anymore, it stopped to prevent any overfitting. And we used separate models for each of the outcomes, excess weight loss, type 2 diabetes, and OSA, rather than building one model to try and do all three. So there were 49,800 patient identifiers in the registry, and after basically excluding all of the duplicates and those where there were insufficient data available, we had a final figure of 13,976 eligible patients that could be used in making our machine models. Here's basically the demographic data across them all. The mean age was around 45, pre-op BMI 44.5. Unsurprisingly, the most common procedures were sleeve and bypass. A reasonable number of diabetics and sleep apnea patients reported, and the mean excess weight loss across the whole registry was 66%. And we did achieve a median follow-up time of pretty much around 12 months. So going on to the prediction models, for excess weight loss, 11,700 patients approximately were included, with a mean absolute error of 16.5%, root mean squared 21.57. The R squared, which is essentially how well the model is predicting against reality, was around 0.35. So there is some predictive signal, but it's not really a direct, I would say, independent predictor. These are the factors that the model found to be the most predictive of excess weight loss. Pre-op BMI is dominant, followed by procedure type and age. And these are clinically plausible, so the model seems to have some face value. This scatter plot shows along the x-axis the actual excess weight loss for patients versus the predicted excess weight loss. The blue line is a line of best fit, so it does show that the machine learning model has captured a predictive signal, but at an individual level, it's still quite imprecise. For resolution of diabetes, the model achieved an area under the curve of 0.65. So for context, 0.5 is flipping a coin, so 0.65 is some capture of predictive signal, and with key predictors including severity of diabetes, HbA1c and BMI. So there's a moderate predictive signal, but again, not strong discrimination. And this ROC curve demonstrates that moderate performance. It's above the diagonal, which indicates some signal, but I would say it's far from being a strong classifier. For obstructive sleep apnea, on our revised model, since submitting it to this meeting, the performance was actually quite weak. An error under the curve of 0.59, and accuracy 0.55. There were some key predictors. Pre-op BMI and functional status was a good predictor of resolving sleep apnea with weight loss surgery. But this overall suggests that probably the model has very limited predictive value in assessing whether obstructive sleep apnea might resolve from metabolic surgery. So overall, the strongest signal was for excess weight loss. That seems to be the most likely thing that these models will be able to predict. Type 2 diabetes remission partially, but not really for sleep apnea. And these predictors that came out as dominant features in these models were clinically plausible, and there was no overfitting in the metrics. So where does that place the UK in this area? Well, we've seen that machine learning models can capture a meaningful predictive signal from UK national data, particularly for weight loss, but there are some significant limitations. The registry is voluntary, which I think is a key cause of substantial missing follow-up data. We went from 45,000 patients down to around 14,000 patients, which is a massive data loss. And many important factors such as behavioural and psychosocial variables are not really captured in our registry. So further work should focus on enriching our national registry, enable to have richer variables and hopefully enhance predictive performance in future. And that have implications for national policy, in planning services, particularly in a newer era where there are more multimodal treatments for obesity. Thanks very much.
Okay, thank you. Any questions from the audience? Yeah.
Congratulations for your wonderful study and presentation. How do you explain that in your model you could not predict the resolution of sleep apnea? What was the reason for that? Because we have studies, we know that sleep apnea can be treated after weight loss. So how do you explain that your model didn't predict this?
Yeah, so I think there's several factors at play there in why it wasn't able to predict that. So in the registry, we collect data on obstructive sleep apnea based on purely on the question of does the patient have obstructive sleep apnea? So there's no real objective measures that are entered into the registry, stop, bang, Epworth or anything, and whether they're on treatment for obstructive sleep apnea. And that's a fairly broad term, you know, a weight loss journey is your treatment for obstructive sleep apnea. So I think that vague data going in is what's produced all this variance, and I don't think it's been able to be borne out.
Do you know if the predictive performance differs between operations, for example, sleeve and Roux-en-Y gastric bypass?
We haven't tried that yet. I think that's definitely a feature. One of the operation type did come out as an independent predictor for excess weight loss. But in terms of the performance for, say, the other outcomes in those individual patient groups, so maybe, you know, we haven't looked at this, but speculating, it might be that bypass helps predict sleep, you know, the predictive power in these models for sleep apnea might be better in individual operations or patient groups, diabetics such as. So I think there is some subgroup analysis that could be done on top of this, yeah.
One of the problems with the data, even from our work in our unit, is that the lack of follow-up data in certain variables. We're trying to fix that. When MBS fixes it, we'll be able to provide more clear data. This is the first shot at this database with the AI, and hopefully in the longer term we'll be able to get more information.
I have a question. Why have you used excess weight loss instead of total weight loss? Maybe your sensitivity could be higher?
Yeah, I think that's a very good point. That's something for us to go back and look at. You know, I think that's a very valid point. It'd be quite straightforward for us to go back and do that quite quickly. Yeah.
Okay. Any other questions? Thank you very much.
Next speakers, Michael William from Sweden. Cancer reported psychiatric profile, predict development of abdominal pain after bariatric metabolic surgery.
So hello, my name is Michael William. I'd like to thank the scientific committee for allowing me to present this data and the moderators, and I'd like to thank you for being here at the Congress. So myself, I'm a senior or very senior surgeon, and this paper, which you can read the title of, is a study done by two surgical departments in Stockholm and collaborators in statistics and psychiatry at Uppsala University. So the background is that chronic abdominal pain is seen in a fairly small proportion, just a few percentages, but I've spent more or less 25 or 30 years of my life meeting these post-bariatric problematic patients rather than seeing primary surgical candidates. And as you all obviously know, the quality of life can be severely compromised with reoperations, malnutrition, and dependency problems. We all know that anxiety, depression, and some neuropsychiatric diseases are more common in the obese population, those who are coming to metabolic bariatric surgery, compared to the general population. And therefore, the aim was to see, is there something in the psychiatric profile of the patient before surgery that can help us understand why some develop this sensitivity to abdominal pain or not. And this study is limited. It's just the 2-year data of 526 patients. Originally, we included 1,000 patients, and as usual, it's around 70% women with 45 or 42 years of age and slightly less heavy than ordinarily. More or less half of them were operated with sleeve gastrectomy and half with gastric bypass, and that's mainly due to that we did a big randomized study on these two procedures during these years. Before and at 1 and 2 years, 526 of those 1,000 completed all 4 instruments to evaluate psychiatric aspects and quality of life, as well as abdominal pain. So the instruments we were using, it's the gastrointestinal symptom rating scale, GSRS, and in that one we only used the subscale of abdominal pain for analysis. Then we have the pain catastrophizing scale, which was very new to me, but it's 13 statements on how you feel or think regarding the risk of being confronted with pain. Then we have 2 quite common instruments for anxiety and quality of life. So firstly, we wanted to know how are these variables associated with abdominal pain before surgery, and how are they affected by surgery, and to what extent could possibly the variables of pain, catastrophizing thoughts, anxiety, and depression predict future results on abdominal pain. So firstly, there were strong correlations, or fairly strong correlations, between the psychiatric factors here, but regarding abdominal pain, not so strong actually. But the good thing with this study is that it really underlines the beneficial effects on anxiety, depression, and catastrophizing thoughts. If you can see here, and they stay lower than before. Abdominal pain, strangely, not any difference at all. So we were interested in this PCS scale. We divided it into 4 groups, and as you can see here, this is data for year 1 and 2, and this is the 4 scales, the highest degree of pain catastrophizing. What happens in this group? It decreases dramatically. It's a pattern that you will see in all of these instruments. Anxiety decreases as well, and depression decreases. But abdominal pain has a much bigger variance, so it's difficult to see a clear pattern here. So our conclusions are that those who are at the highest level of abdominal pain at year 2 seems to have a much higher score on catastrophizing thoughts and feelings at baseline. This correlation between abdominal pain and PCS was fairly weak, but the improvement in PCS after surgery was much higher compared to the other variables. And compared to anxiety and depression, catastrophizing thoughts seems to have a possible or could be part of the explanation why patients feel this. So the final conclusion is very positive. We report marked and sustained improvements in anxiety, depression, and degree of catastrophizing after metabolic bariatric surgery. And we suggest that this new scale, the pain catastrophizing scale, could possibly help in if you see a very high level before surgery and you realize that for perhaps the 6th week after surgery, they already developed some kind of discomfort or pain, that they could be given some extra psychiatric support. So this was the first 2-year report. I hope to be able to come back with a deeper analysis and 5-year data in a few years. Thank you.
Any question from the audience?
Good morning. Thank you for your presentation. I'm a clinical psychologist. I work in a bariatric center in the UK. We pay attention to the level of pain threshold and pain management in our patients, but did you see, because I see in my clinical practice that patients that present with fibromyalgia are usually the ones that I see at a higher risk of having a lower threshold or pain tolerance threshold after bariatric surgery and experiencing worsening of depression associated with postprandial pain or reconnecting with their bodies after the operation. I don't know if you saw anything with regards to people with more complex pain conditions, chronic pain, fibromyalgia.
No, this is just inquirers' reports, so we don't have the personal data for every patient to see if they actually had any somatic reason for pain or psychiatric reason for pain. So it's just a way to see if, how does the subjective reported psychiatric condition affect what's going to happen later on. But which kind of instrument were you using before surgery? I didn't get that.
Well, we don't use a specific pain instrument before the operation, but we talk about that in the clinical assessment to see if they present with more complex pain conditions. But in terms of the clinical implications of your results, then you would advise using the pain scale prior to surgery to have a more clear profile of the pain condition of the patient, and then adding more psychological support or psychiatric support before and after the operation to help them cope with the levels of pain?
I will answer that question next time.
Okay.
After 5 years, when we know a little bit better how to interpret the data that we had.
Okay. Thank you so much.
Thank you, Michael, for your beautiful design of your topics. Sorry, I'm going to make just a small question. Okay. 30 years we was worried about to lose weight. 20 years ago we was worried about to resolve the diabetes and hypertension. And I'm very happy now because I think studies like yours is going to increase so much now because we are very ambitious. We are taking care about other aspects. Maybe in the past, surgeons don't talk about psychiatric problems, don't talk about chronic pain, and any others is so important. But my question is, do you think could be a relation between the microbiota and the possibility to have SIBO, a small intestine growing in this patient, trying to explain how some of these patients, independent, they have a psychiatric profile previous to surgery, have this chronic pain?
I actually think that, but in my experience, in my practice, we're talking about really severe pain, going into redo surgery, etc. And the SIBO and or the IBS, I think it's a real problem for the patients, but it's not my speciality. So if I would encounter a patient with severe problems, then I would send them to a neurogastroenterologist.
Thank you.
Another question? No? Okay.
So it's my great pleasure to introduce the next speaker, Professor Panayotis Lainas from Greece. He will talk about intussusception after Roux-en-Y gastric bypass.
Thank you very much, Mr. President. For those who were in the quiz battle yesterday, this is the one of the questions was based in the results of this study. So it's a great pleasure for me to be here in Malaga, in beautiful Malaga, to this wonderful Congress and present this study on intussusception after Roux-en-Y gastric bypass for the treatment of severe obesity, a systematic review and meta-analysis. These are my disclosures. These are the participating centers and my colleagues that participated in this study. So we all know that Roux-en-Y gastric bypass is number 2 procedure worldwide in terms of metabolic surgery today. And of course, long-term complications exist in Roux-en-Y bypass. One of the complications is jejunal intussusception. It's a rare, under-recognized, potentially serious complication after this procedure. And despite its rarity, delayed diagnosis of intussusception can lead to severe consequences. The incidence of this complication is unclear. The etiology, altered intestinal motility after Roux-en-Y gastric bypass, the altered bowel anatomy, and ectopic pacemakers in the Roux limb. This motility and disorganized peristalsis, mesenteric laxity due to weight loss, and of course, in some cases, mechanical issues such as staple lines, anchoring points. The presentation is non-specific, and of course, there's no standardized management strategy. So this creates a critical need for synthesis of available evidence. So this is what we did. We performed a systematic review and meta-analysis on this topic to evaluate the incidence, clinical presentation, diagnostic modalities, management strategies, and recurrence of intussusception following Roux-en-Y gastric bypass to inform clinical practice and improve decision-making. So we perform a PRISMA-guided systematic review and meta-analysis. Database is PubMed, MBS, Corpus Web of Science. Search period up to June 2025. Outcomes studied, incidence, recurrence, and management. The methods, the keywords, you can see them here, and of course, a robust statistical analysis. The results, 9 studies included, mainly studies from the USA and 2 studies from Europe, Germany, and Sweden. A total of 223 patients included in these studies. 92% were female, mean age about 40 years old. More results, the mean onset about a median of 4 years after the surgery. We had data for the alimentary limb length and biliopancreatic limb, but not for all studies, so it was not conclusive in our analysis. This is very important, the incidence. The incidence from this study is 0.7%, so keep this study in mind, it's 0.7%. Symptoms, abdominal pain, of course, nausea and vomiting, half of the cases, chronic pain, distension, peritonitis. Diagnosis, the gold standard is CT scan, but there was also in some studies upper GI series and endoscopy. The treatment, laparoscopic surgery most commonly, bowel resection or reduction for most cases, and enteropex implication in some cases to avoid recurrence. Most cases were retrograde intussusception, which is the contrary of what happens when we don't have a Roux-en-Y gastric bypass. Normally, intussusception in most cases is anterograde, but in this case, 84% of cases were retrograde. Recurrence, 15.9%. Recurrence, mean time to recurrence, 23 months. So recurrence is clinically significant and not fully understood. So this is our proposed evaluation algorithm in a patient with a history of Roux-en-Y gastric bypass presenting with acute or intermittent severe abdominal pain, nausea, and vomiting. If the patient has all this, you have to go directly to emergency surgery. If the patient doesn't have this, you perform a CT scan. And if the patient is a pregnant woman, you perform an MRI. Intraoperatively, if you find ischemic bowel, you should perform resection and, of course, revision of the jejunostomy anastomosis. If the bowel is viable, you should perform reduction laparoscopically or convert to open and do it manually. And of course, consider recurrence prevention by performing enteropexy or placation. So to conclude my study, this is a rare but important complication after Roux-en-Y gastric bypass. It requires a high clinical suspicion. It occurs years later with non-specific symptoms, so you should have this in mind. Delayed and subtle presentation makes diagnosis challenging. CT scan is a diagnostic standard. It will guide your management. Surgical intervention remains the cornerstone treatment. Reduction of the bowel if it's viable, resection, enteropexy if not. Recurrence is significant, about 16%. Of course, limitations of the study, limited evidence, need for prospective study. It's not easy to perform prospective studies on this, but we need that. And of course, future research is essential for standardized management. We were happy to see this study 2 weeks ago published in Obesity Surgery. We're very happy about it. And these are my colleagues who were in the study with me. Sonia Chiapetta from Italy, Mohammed Khemasharavi from Iran, and Erdan Qasir from Qatar. And before closing my talk, I would like also to invite you next month in Athens in the AES 2026 Congress. We organize it there. We wait for you there. I'm happy to be part of the organizing committee, so I hope you'll all be there. And also in Toronto in a few months for our Congress, our World Congress. And finally, I want to invite you to this course we're organizing with distinguished colleagues in North Sea Academy in Belgium next March 2027. Thank you very much, and I'm open to questions.
Thank you. Are there any questions from the audience? Yes.
So, very nice presentation.
Thank you.
Difficult topic, because radiologists tell me that they see invaginations all the time as a natural phenomenon. So the diagnosis depends on a fairly long invagination in the enteron. What do you think, since you've read this, what's the data, the scientific data to say that enteropexy will prevent?
There are cases of enteropexy reported with good results. We have some cases where enteropexy was performed and there was a recurrence. So I don't have an answer to this yet. We don't have so much data. It's data only from 223 patients, which is very few patients, 9 studies. So it's really a topic which is not studied enough. And it was difficult, what we saw in the literature, it's very difficult to perform a prospective study on this. I mean, it's feasible, but you need many patients to have just some cases of intussusception, because it's a rarity. The incidence we found was, after analysis, was 0.7%. So it's a very rare complication. But of course, it would be great if high volume centers could study this in a prospective way. I think that enteropexy is a good technique, and if you have, for example, this type of complication, you should do it. I believe enteropexy is good. Plication, I'm not a fan, but enteropexy is a good one. You should do it, actually. You should try to prevent recurrence.
Do you think that there is an association between amount of weight loss and the risk for intussusception?
Yes. There's, when patients lose weight, there's mesenteric laxity. So everything is more movable, so you can have this. And there's also alterations in motility after Roux-en-Y gastric bypass. So it's, yeah, there's for sure, I believe there's a relation to that.
Any other questions?
Thank you.
Okay, thank you.
Okay, the next presentation is about optimizing surgical sequencing for concomitant cholecystectomy during laparoscopic sleeve gastrectomy, reducing intraoperative and postoperative challenge.
Thank you very much for the opportunity to present a part of our activity in a single center of excellence in bariatric and metabolic surgery from Bucharest, Romania. I have nothing to disclose. Because of the 2 lists of conditions, we have the chance to have higher probability to encounter in our activity this association in everyday practice. But still, we don't have clear recommendation about how to treat the patients the asymptomatic patients with gallstones and concomitant sleeve gastrectomy. We don't know which strategy is the best to perform first laparoscopic sleeve gastrectomy or first cholecystectomy. Which are the difficulties? Which are the solutions? The strategy is important to know, but we don't have too much information till these days. Therefore, we are pleased to share with you a part of the trip of our trip in this area from our experience. So in the past, we started in 2014 with a strategy for these patients. First we perform laparoscopic sleeve gastrectomy, and after that laparoscopic cholecystectomy in the same operation. And in the second period of time, starting with 2019, we changed it a little bit. We first performed the laparoscopic cholecystectomy with routine intraoperative cholecystectomy, and in the second place sleeve gastrectomy. These are the exclusion criteria. Some details about the technique was a resection of 35 French bougie with overswing and fixation for a proper geometry of the gastric tube. And the technique for cholecystectomy was fundus first manner, and with no routine intraoperative cholangiography for this period of time. This is the baseline data for the first group with 249 patients, and we find challenging situation in 8.4% of these patients. And I want to show you what kind of situation we found it. Situation 1, very difficult cases, 12 cases because of the higher BMI, modification of the anatomy, hepatomegaly with retracted gallbladder under the liver, with some modification that weren't see the ultrasonography in the preoperative evolution. And as you can see, the gallbladder is somewhere there. And it's not so easy, of course, to perform. And in some cases, we have adhesions, and we don't know about these adhesions in the preoperative part of the evaluation of this kind of patients. And in this situation, we had a prolonged time, surgical time, of course, and we had some complication like rhabdomyolysis, and we had an increased length of the hospitalization. So the final was good, but was unexpected for us. In the second situation, with 5 cases, we had postponed the cholecystectomy because of the prolonged surgical time for laparoscopic sleeve gastrectomy, and because, of course, of the difficulties in the intra-abdominal cavity due to a higher BMI. Was a good decision at that time, but unfortunately 2 of these patients developed acute cholecystitis at 3 and 4 months after the sleeve gastrectomy. So another situation, the third situation, with 2 cases with post-operative biliary pancreatitis in the 13 days after the operation and 18 days after the laparoscopic sleeve gastrectomy with cholecystectomy. And for that, we proceed to have a good diagnosis with magnetic resonance cholangiopancreatography, ERCP, and sphincterotomy with extraction of the stones from the common bile duct. As you can see, here is the sleeve inside the endoscopy at the 13 days postoperatively in a good evolution, and the stone that was taken out after we checked that the sleeve is in a good evolution with good healing at that time of the operation. The first situation it's about the common bile duct lithiasis. In one case, we found it during the operation, and for this case, we choose it to place the drainage tube, the transcystic drainage tube, because the anatomy doesn't allow us to do at that time a cholecystectomy. So like you can see, the sleeve was done first, and after that was the cholecystectomy. And the fifth situation, again, common bile duct lithiasis, and in this case we choose, and we had a good result with a cholecystoscopy. We choose for this patient to, of course, to check it with intraoperative cholangiography because of the larger cystic duct, and after that, after the intraoperative diagnosis of the common bile duct stone, we assume that we can do cholecystoscopy with extraction with the basket of the stone. The second period of time, the strategy was in the other side, with first laparoscopic cholecystectomy with routine intraoperative cholangiography, and after that laparoscopic sleeve gastrectomy in the same session. This is the group with 146 patients. Here in this strategy, we had 7 challenging situations, almost 50% lower than in the first period of our experience. The first situation was with difficult cholecystectomy in 4 cases due to higher BMI value and due to gallbladder modification, but without correlation with the preoperative ultrasound data. Of course, we postponed the laparoscopic sleeve gastrectomy at least 1 month after the operation. These are the images inside. We didn't know this before in the preoperative evaluation, and these are the conditions in one case, and in the other one, as you can see, are not the ideal conditions to have a very fast cholecystectomy and to allow us to go further with the laparoscopic sleeve gastrectomy. The second situation for this period of time was a common bile duct lithiasis in 3 cases, and in this case we assumed to perform an ERCP with sphincterotomy, and of course we postponed the laparoscopic sleeve gastrectomy at 1 month. And what we have learned from our experience, we learned that in patients with higher BMI, the ultrasonography could be less sensitive for evaluation of gallbladder and common bile ducts, so we can expect some situations that are not so easy to treat during the operation. Cholecystectomy could demand more surgical time than laparoscopic sleeve gastrectomy in patients with higher BMI, and because of that, it's difficult to estimate the cholecystectomy time. In many of the cases, we had an unrealistic planning time for surgery, and during the surgery, we see that we need more time than we expect. So, when we proceed with the strategy with concomitant cholecystectomy and intraoperative cholecystectomy, we had some advantages, and still nowadays, because we do the same thing. In case of common bile duct stones, we have a modified stomach, so will allow us to perform an ERCP with sphincterotomy in the same operation and to postpone, of course, the laparoscopic sleeve gastrectomy in a safe manner. If we'll have, or it's possible to have biliary incidence, because the cholecystectomy is not the easiest operation in bariatric patients, sometimes it's worse than a sleeve gastrectomy. So if you had incidence, then is the time to postpone the laparoscopic sleeve gastrectomy, and it will be more easy to manage this complication after the first operation. And you can avoid the biliary complication like jaundice, like pancreatitis after the laparoscopic sleeve gastrectomy when you let the common bile duct unexplored and you don't have too many information about what's happening with the stones in the biliary tract. For us was a safe attitude, and this is our algorithm. At this moment, of course, with the time we will probably improve it, but what we did till now, we had good results and we trust in our decision. So if you have a gallstone, patient with gallstone, asymptomatic gallstone and obesity, with suspicion, of common bile duct stones, do an MRI preoperatively. If has not, do a cholecystectomy, but first laparoscopic cholecystectomy and after that sleeve. After that, you can go more, and in many of the cases when you don't have preoperative suspicion of common bile duct, it's better to start with laparoscopic cholecystectomy first, and after that to check the biliary tract intraoperative cholecystectomy and see what you'll do after that. If you'll do only cholecystectomy with sphincterotomy, or you'll do the second step like laparoscopic sleeve gastrectomy. Thank you very much.
Thank you very much. Any questions on the floor? Yeah?
Very nice presentation.
Thank you.
In the Swedish quality registry for bariatric surgery, we have noticed that when you add another procedure at the same time, you increase the post-operative complications significantly. So I'm a little bit skeptical to your conclusion that it would be good to do it at the same time. But my question is actually, what was the indication for cholecystectomy? Just the finding of gallstone, or did they have?
No, to find it. We know it about that gallstone. The indication was more in the area of prevention to don't have cholecystitis and jaundice and pancreatitis after that. Because as you said before, okay, you look only at that complication when you do this association, but you forgot about the patient with lithiasis. They are coming in acute situation. And if you have a patient with a BMI over 50 with pancreatitis, I'm so sure that your anesthetist will not be very happy. And I think we must have this in our mind.
I think that in the majority of the cases, it would be easier to do the cholecystectomy after the sleeve resection and when they have lost like 20, 30 kilos. But if you're afraid of really acute cholecystitis, I understand it, but it seems like you're going back like 40, 50 years in time. When in open bariatric surgery, they took away the gallbladder for prophylactic reasons without any gallstones.
But this is not prophylactic because we have the gallstones. It's not a prophylactic cholecystectomy.
Okay.
Symptomatic. We're symptomatic in all the cases. Not only the presence of the gallstones, but also symptomatic. That's why you've seen the images and signs. So not as we used to do 20 years ago, that without any reason, just prophylactic to get it out. We have medication for it. But you're right, thank you for your question.
Thank you.
Thank you for this wonderful presentation, and congrats for getting out of this difficult situations intraoperatively. I have two questions. First of all, did you change your selection criteria for your patients after these results in terms of BMI or other comorbidities? And second, in my practice, what I'm doing when I have hard cases like that of cholecystectomies, I use ICG. Do you use it? Do you have experience on that?
We use ICG. Of course, we use it when we have difficult anatomy there and we need to see, to understand the anatomy, we use it for each case, of course. And regarding the question with the BMI, we adapt more our protocol to the conditions of the patient, because we are a team that we treat bariatric patient, and we expect and we know how to do a technique in that cases. So for us, sometimes is not an issue to don't go with the proper surgical treatment for the patient if has a larger BMI.
Yeah, the question is, if you have a patient with a BMI of 75,
Yeah.
would you do that, or would you say I will do it in 2 stages? That's the question.
Of course, this is the large case, the biggest case. Of course, here I think it's wise to check first, go intraoperatively and check the area of the gallbladder, see if there are some modification, and after, if not, go and do the sleeve.
Okay, if the speaker gives you the permission, first of all, thank you for your work. It's amazing. To ask a question to the audience, how many of you decide to do the same at the same time, cholecystectomy and bariatric surgery? And how many of you decide to do in 2 times, 2 stages? Okay, close, the same. And if you decide to do it in the same procedure, cholecystectomy and bariatric surgery, you start with the gallbladder. So many people. And you start with the bariatric surgery, previous, down gallbladder. Okay.
This is the case of a bypass, not a good idea.
Okay.
Congratulations for the algorithm. Do you think could be the same algorithm with gastric bypass?
If could be. I don't think so. I don't think so.
Thank you very much. Excellent presentation.
Thank you.
Any other questions? Okay. You have the microphone.
Hi there. I'm a medical student from London, so apologies if the question is a bit basic. But if you were to split them into 2 surgeries, the bariatric surgery and then the cholecystectomy, would that increase the risk of adhesions and those complications later down the line? And would it actually be better, as you said, to do it in one? Is that a complication that occurs? Or?
are two different areas of surgery. Then under the left lobar and under the left liver lobe and under the right liver lobe. Let's say if you'll do sleeve gastrectomy first, you expect to have adhesions there and you have a clear area, okay, and vice versa. But of course, if you'll do a sleeve and you'll have a fistula and you'll let the gallstones there and you'll have a patient with fistula and you'll treat it a long time, probably will be not so easy to treat it during that period of time. So overall, I think we can decrease a little bit the chance of complications that come one after other. I think we must have our patient globally, not only sleeve, must think what's happening if the sleeve will have a complication, what will happen without lithiasis there.
Can I just comment on this?
Just the last question, please.
Just a comment on that.
One word.
I agree partially with your statement, but the current literature shows that we should, for rural-wide gastric bypass, we should do the cholecystectomy at the same time, and for sleeve, ideally we do it in 2 times. That's the data we have actually, but we're waiting for your data to change this attitude maybe and see what are the results.
We'll see. Thank you.
Okay, thank you very much.
Thank you.
And let's go to the next presentation.
Next speaker, David Merino from Spain. Time-free from high-risk obesity after 1-step versus 2-step duodenal switch, a propensity score single-cell analysis.
Well, good morning to everyone. Thank you for the presentation. I'm David Merino from Barcelona at Beirut University Hospital. I'm going to present the results of a study we conducted there, which was time-free from high-risk obesity after 1-step versus 2-step duodenal switch, a propensity score single-center analysis. And first of all, I have nothing to disclose. And as a bit of an introduction, just to say that the duodenal switch is the best option for patients with BMI over 50 and associated metabolic disease, as it offers a superior weight loss when compared to other techniques, and it has the highest metabolic remission rate, being over 75%. However, it is technically demanding. This has led many centers to develop a 2-step strategy where the sleeve gastrectomy is performed first, followed by the duodenoileal bypass. If the patient presents itself with weight regain or insufficient weight loss, that watching weight strategy may have some theoretical advantages as it simplifies the second procedure. You also can identify those patients who respond adequately to the sleeve gastrectomy alone, and maybe to avoid the hypoabsorptive surgery in a patient who doesn't really need it. When looking at the existing studies, there is an aspect that hasn't been examined yet, which is the dynamic evolution of time-free from obesity and its related diseases, not just the final result at a single time point, but the trajectory. So how long patients actually stay with a BMI under 35 and free from metabolic disease? This is the question that this study addresses. So we conducted a single-center retrospective study where we included all the patients who underwent a duodenal switch at our center between 2014 and 2023. That was 454 patients, being 352 of them in a direct duodenal switch and 102 of them in a 2-step duodenal switch. From those, there were 25 patients that were excluded due to the missing pre-sleeve gastrectomy data. And with the remaining patients, a matching process was performed using a propensity score in a 1-to-1 ratio, adjusting by basal BMI, sex, and age. This yielded to homogeneous cohorts of 75 patients each. The outcomes of the study were short and long-term complications, mortality, percentage of total weight loss, the proportion of patients who stayed with BMI under 35 for every postoperative year, and the proportion of patients who stayed free from metabolic disease per year. So after the matching process, we obtained these 2 cohorts. As you can see, are comparable cohorts, as they don't have statistically significant differences at the baseline characteristics, being almost 70% of the patients female with a mean age of 43 years and an initial BMI of 55-56. The proportion of diabetes, hypertension, dyslipidemia, and obstructive sleep apnea were similar between the groups. And also all the standardized mean differences in every variable were under 0.2 after the matching process. This is a result of a good matching process. And on the 2-step groups, the mean interval between the sleeve gastrectomy and the completion of the duodenal switch was 24.5 months. Regarding safety results, we can say that there were no differences between both strategies. They had an overall short-term complications rate of 14%, being 6% severe, with no differences between the groups. We had an anastomotic leak in each of the groups and a 0% of 90-day mortality. There was also no differences in long-term complications, with a 5.3% of them. There were no cases of refractory diarrhea or malnutrition, and there was no need for revisional surgery for nutritional reasons. There was also no significant differences between the group in the need for nutritional supplementation, so we can conclude that the two-step dual strategy does not reduce the preoperative complication risk. Both strategies have a similar safety profile. When we look at the efficacy outcomes, there is a significant advantage towards the direct DS group, with a 5-year results of a mean VMI of 29.8 versus 32.5, a percentage of total weight loss of 45.4 versus 42%, and a percentage of excess weight loss of 75% versus 70%, being all the three comparisons statistically significant. While these differences may seem modest, they take on to a different dimension when we analyze them and we evaluate them on terms of time. That is initially shown in the two graphics above. You can see in blue the direct group and in green the two-step group. The direct group consistently has higher results at every time point. That leads to the next slide with the main finding of the study. That is what happens when we evaluate the proportion of patients who stay with VMI under 35. As you can see, the direct group kept this threshold steadily over 80%, whereas in the two-step group, at the first year is only 14%, and it reaches 70% at the 5th year, being all the differences at every time point statistically significant. When we look, or a similar thing happens when we look for the proportion of patients who stay free from metabolic comorbidities. From the 2nd year to the 7th year, there are statistically significant differences in the comparison, being at 5 years, 66.7% versus 57%. So direct duodenal switch is associated with a significantly longer disease-free period, and all those years that a patient stay with a BMI over 35 and with active metabolic disease are not neutral, they can carry a cost in life expectancy and also in quality of life. So to sum up, a bit of key messages would be that both strategies are comparable in terms of safety, so safety should not be the deciding factor between them. There is a superior disease-free time period with patients undergoing a direct duodenal switch. There are both clinical and statistically meaningful differences at 5 years outcomes, and there's also a clinical implication. The two-step watch and wait strategy can carry a real cost in the disease-free time, so it's something we have to be aware before choosing between the strategies. So that will be all. Thank you for listening.
Any question from the audience?
Hello, my name is Philip. I'm a surgery resident from the Netherlands. I have a question. What was the mean time from the sleeve gastrectomy to the second procedure? And how many patients, for example, had the two-step approach and were at the 5-year follow-up?
And the mean time was 24 months. In the two-step group, there's a mixture of patients who were planned for a two-step strategy and patients who were rescued due to weight loss or insufficient weight regain. The second question was the follow-up.
How many?
At 5 years, more or less, 65% of the patients had the follow-up.
Okay, so also 65% from 75 had the two-step approach, and you had 5-year follow-up of them, or?
No, the 5-year follow-up is for all the patients in the study, the 400 patients. I don't know the exact value for the two-step patients. From all the cohort, it's 65% of 5 years.
Okay, thank you.
Any other questions?
So, thank you. Firstly, I do not agree by saying that DS is the best procedure for BMI over 50. That could actually be discussed. But my question is, this was a propensity score matching, but what actually decided in which group the patient was the first two-step procedure the first years, and then you switched to the one procedure, or what decided which group the patient was in?
It was retrospective, so the patients were classified before the propensity score analysis, so it is all retrospective. We look at our historical series of DS.
I understand that it's retrospective, but what was it just the doctor who said that this patient will be in one procedure and another doctor saying this one will be two procedures? How did you decide?
Usually, what we do at our center is patients with BMI over 60. That's a two-step strategy, and between 50 to 60, it depends. We try to do the direct procedure. As you can see, the difference is 70 to 30, and the two steps sometimes is decided in an intraoperative way, depending on the findings in the surgery.
How did you do the propensity score with patients? I mean, you had patients in one group more than 60 BMI, and in the other, I mean, if you want to publish a study, the reviewer will tell to you, will ask you, how did you do the propensity score with patients from 45 or 50 to 60, and the other group 60 to 80
No,
to
no, the
75?
patient in the two-step approach group were more than 60. The decision was during the committee, they decided which strategy they could using in each patient is just clinical decision of the multidisciplinary committee.
Yeah. I actually thought that you might have started with a two-step procedure and then, so then there would have been a learning curve problem, but this was not the case. Okay.
We started with both procedure as primary
Okay.
DS or two-step approach. So it was just clinical decision.
So it's not the same surgeons, or is the same surgeon?
The same surgeons since 2014 to 2020, and then
You are a team with a lot of experience on SARIES procedure. I'm going to make you a last question. If your clinical practice, you have to decide to make SARIES just in one time, what's the best patient? Age, gender, BMI, illnesses?
That would be a patient with a BMI between 45 to 55, and I don't think there's a difference in the gender. It's true that in women they are maybe more feasible, but that would be BMI between 45 to 55, and we try to do it in a one-step way.
Okay, thank you very much.
So the next speaker is Tans van Gelder from the Netherlands. She will talk about 5-year outcomes of quality of life scales after bariatric surgery.
Yes. Thank you for the introduction. My name is Tans van Gelder. I'm a PhD candidate bariatric surgery at the Obesity Center Amsterdam. And today I will present the results of our study of 5-year body Q assessment of 6 health-related quality of life skills after Ronai gastric bypass versus sleeve gastrectomy. I have no conflicts of interest. Starting with some background information, according to the IFSO Global Registry, 60% of bariatric surgeries is a gastric sleeve, opposed to 30%, which is a Ronai gastric bypass. In the Netherlands, we do the Ronai gastric bypass more often than the gastric sleeve. Depending on literature, it's around 60 to 80%. I think we all know that the Ronai gastric bypass leads to more total weight loss. However, this is not the same as a better health-related quality of life. So on paper, the Ronai gastric bypass does appear superior to the gastric sleeve. However, the question is what matters most to the patient. Is it total weight loss, percentage total weight loss, or is it health-related quality of life? So therefore, the aim of the study was to assess the 5-year outcomes on 6 health-related quality of life skills and corresponding minimal important differences after an gastric bypass and sleeve gastrectomy. We conducted a prospective multi-center cohort study in which we had included a total of 391 patients who underwent MBS between 2017 and 2019. For the health-related quality of life, we assessed 6 body Q health-related quality of life skills, which were body image, physical function, physical symptoms, psychological, social and sexual well-being. And we measured this preoperative and after 4 months and 1 to 5 years postoperative. We looked primarily at the health-related quality of life trends between both procedures, and secondary outcomes were weight, BMI, total weight loss, associated medical problems, and a minimal important difference. If we look at the results, first of all, we have the baseline characteristics here. We saw that there was a significant difference between both groups for age. Patients who had underwent coronary gastric bypass had a significant higher age. There was also a significant difference for weight and BMI, with patients who had underwent a sleeve, gastric sleeve, had a higher preoperative weight and BMI. For the presence of associated medical problems, patients who had underwent a coronary gastric bypass had more often hypertension at baseline, dyslipidemia, sleep apnea, osteoarthritis, and reflux. And patients who had underwent a gastric sleeve had more often a psychiatric background. If we look at the weight and total weight loss, we see 3 graphs here, but the most important one is the last one, which is the total weight loss. There was a total weight loss of 33% for the coronary gastric bypass group after 5 years, opposed to 26% in patients who had underwent a gastric sleeve. Here we have for associated medical problems. These are the results after 5 years. Preoperative and after 5 years, we saw that there were no significant difference between both groups. And then here are the results for the health-related quality of life. So body image, physical function, physical problems, psychological, social, and sexual well-being. You can see that there are similar trends between both groups. And if we look after 5 years, for all 6 of them, there were no significant differences. We also assessed the minimal important difference. The minimal important difference is the smallest change in a PROM score that patients perceive as clinically relevant. So instead of thinking a score of 30, we don't know really what it is and what it means. We have said in a study, my colleague Philip, that for instance, body image, a score of 5 and increasing to 5 means that there is a minimal important difference which is clinically relevant to the patient. So if a patient goes from 30 preoperative to 35 postoperative, there is a clinically relevant difference which the patient actually notices. And these are the results for the minimal important differences after 5 years. Also here we saw that there were no significant differences between patients who had underwent a coronary gastric bypass and a sleeve gastrectomy after 5 years. So what we saw was that there was greater weight loss after coronary gastric bypass, which is in line with current literature, but comparable health-related quality of life between both procedures. The patient-reported outcomes do not always reflect the objective outcomes, and both procedures achieved body Q scores that were comparable to those of a general population. However, there were a few limitations. The MID was based on baseline versus follow-up, so this doesn't give us insight into changes between the follow-up time points. And also there was some loss to follow-up, which may bias the 5-year outcomes. But in conclusion, we saw a comparable 5-year health-related quality of life after coronary gastric bypass and sleeve gastrectomy. There was a clinically relevant improvement achieved to a similar extent in both groups. And my take-home message would be evaluate the long-term outcomes, not only based on weight loss, but also on quality of life and patient-reported outcomes. Thank you for your attention.
Thank you. Are there any questions from the floor? So how should these findings influence the decision-making when seeing patients and discussing with them bypass or sleeve?
One of the things that will be taken into account is, of course, the total weight loss in procedure decision-making before surgery between the coronary gastric bypass and the gastric sleeve. It's mostly from experience, clinical experience, that patients who aim for a gastric sleeve do not want a bigger surgery than the gastric sleeve is. But mostly what we see in clinical practice is that both patients or patients who had underwent the coronary gastric bypass and the sleeve gastrectomy, they are both as happy with their quality of life. So it brings more insight into decision making beforehand as well.
Yes.
So very nice data.
Thank you.
But how big was the loss to follow-up? And was it different in the two groups?
So we had a total of 150 patients after 5 years, which is quite some attrition. However, we did look into the differences in loss to follow-up between both groups, and there were no significant differences.
Were they privately paying or?
No, no privately paying, no.
Any other questions? Okay, thank you.
Thank you.
Okay, the next speaker is Johanna Vermeer from France. And she talked about centralized management of sleeve gastrectomy leaks, 10 years outcomes from the Ocean Network.
Hi, I'm Johanna Vermeer, a French resident in Lille University Hospital, and I will talk about gastric leak after sleeve gastrectomy. I have no conflict of interest. To introduce the subject, you may know that gastric leak is a staple line disruption that can be diagnosed on CT scan or upper GI endoscopy. It occurs from 1.5 to 3% of cases, depending on the study. It's a serious complication because it may lead to death in about 2% of cases based on small series. Management of fistula is multidisciplinary. It includes surgery, which may consist of peritoneal washout and surgical drainage, or even revisional surgery, like conversion to gastric bypass or fistulojejunostomy. Please note that direct suture repair is not recommended. It also includes interventional endoscopy, which allows endoscopic drainage of the fistula, and also nutritional management should be considered, including prolonged fasting combined with exclusive enteral nutrition as well as correction of nutritional deficiencies. In addition, in our center, we consider that this management must be done in an expert center. Why do we think that? Since 2013, the Ocean Network has centralized the management of severe or complex complications following bariatric surgery at Lille University Hospital in the north of France, receiving patients from across the region. In 2018, we investigated the impact of this organization of care. As you can see, the 90-day mortality rate after sleeve gastrectomy, with or without gastric leak, was significantly lower within the Ocean Network than in the rest of France, and also lower than the anterior period before the initiation of Ocean. So the objective of our current study is to focus on gastric leaks and to describe its management and outcomes in the Ocean Network. This is a single-center retrospective observational study. We included patients with gastric leaks after sleeve gastrectomy referred to our expert center between 2013 and 2023. The primary objective is to assess gastric leak-related mortality at 90 days. Fistula was defined as chronic beyond 12 weeks of evolution. Healing was defined as resumption of oral intake and the absence of enteral nutrition. And endoscopic treatment failure was defined as the subsequent need for surgical intervention. 190 patients were included. Mean age was 38 years old. One individual died following catastrophic antiphospholipid syndrome, representing 1.5% of the cohort, which is lower than other papers. 72% of patients required ICU admission. Chronic fistula occurred in 23% of cases and led to revisional surgery in 95% of them. Overall, 40% of the cohort required revisional surgery, not only for chronic fistula, but also for long-term complications such as late stenosis or severe reflux resistant to medical treatment. In 5% of cases, revision surgery was made very early after the diagnosis of leak due to a large fistula or upon identification of a iatrogenous stenosis of the gastric tube. These findings may support centralization in an expert center with trained intensivists, experienced in the management of obese patients, and surgeons familiar with redo procedures particularly. Now, we noticed that early referral, inferior to 48 hours, may have an impact on time healing. Median time to healing was 17 weeks. In this survival curve, a step indicates a recovery. The blue line is early referral and the red one, late referral. Median time to healing was 50 days earlier if the referral was inferior to 48 hours. Now, if we focus on endoscopy, we found that twist or stenosis was present in a third of cases. Among these patients, leak closure was achieved in only 60% versus 80% in the other group. This finding is statistically significant. Overall, endoscopic treatment permitted healing in 73% of cases. It is consistent with the findings of this study about malignant leakage published in Obesity Surgery. To conclude, a large number of individuals were included, reflecting our expertise in this field. The study reports a very low mortality rate in OCR network on a period of 11 years. However, there's a high rate of ICU admission, reinforcing the need for intensivists experienced in the management of obese patients. In addition, 40% of individuals will require revisional surgery. Those procedures are complex and may require the use of robotic and trained surgeons. In other words, centralization in an expert center is a key to success. And finally, I'd like to say that time to healing is an important information because it is crucial to inform patients about duration of fasting, which can be difficult to tolerate, and to ensure patient understanding and adherence, which is for me the fourth pillar of the gastric leak management. Tell them it is going to be a long cure. Thank you for your attention.
Thank you very much. Any question? Okay.
Félicitations pour cette présentation. Congrats for your study. Great results. I totally agree with you that management should be early. Otherwise, you end up with chronic leaks. So chronic leaks, how did you treat these patients? And how did you decide which type of surgery to do in each case? Was it, I mean, did you have any special criteria, and what were the surgeries you performed?
We performed two types of surgery: conventional gastric bypass, which were more frequent, or fistulojejunectomy. In fact, it depends on the situation of the fistula. If it's very high in the staple line, conversion to gastric bypass could be difficult. So sometimes we did bypass with esophageal anastomosis. And fistulojejunectomy was very, very not frequent. And it was when there is a big inflammation around the fistula.
Other questions? Yeah.
Sorry, but do you really think that total fasting is necessary for 17 weeks? I mean, even if we have a fistula of the esophagus, we would let the patient drink as long as the fistula is drained.
They,
So,
it's progressive.
sorry.
It's very progressive, but at 17 weeks, they can totally eat all they want.
So,
But
It's a support.
it's
We have a complementary support with a natural feeding, which will be added to the per-hour feeding. So at the beginning, as you said,
Yeah.
clear water,
Yeah.
because it will wash.
yeah, yeah.
It will wash. It's quite important because they can drink clear water very soon. Very
Because I thought they were not supposed not to take anything by mouth for 17 weeks.
No.
That okay.
Because most of these patients need a lot of calories to heal and to fight against infection. So that's why the natural feeding is quite prolonged to help them to restore a complete and good.
Okay, thank you. I think we have to move on for the sake of time. And I would like to introduce the next speaker, Vico Vachtera, who will present metabolic bariatric surgery and change in physical activity.
So, thank you for the introduction and hello all. And I have no disclosures to declare. Actually, I gave this presentation like 1 year ago at Venus, where we actually, in the best abstract session when we won this third place also, but after that we had a huge data extraction and now have some new results about the area. So the physical inactivity and obesity are both major cardiovascular disease risk factors as known, and physical activity as such has positive impact on heart function, vascular stiffness, blood pressure, and so on. But individuals with obesity may have difficulties engaging physical activity due to various physical and psychological limitations or barriers. As seen here in this picture, which is quite stigmatizing. This is made by ChatGPT by asking with words that individual with obesity engaging sports, and we can see they are miserable. They are like enduring some pain and some social stigma also. So this is difficult for them. So the physical activity is measured in met hours, where 1 met hour equivalents with 1 hour of walking equivalents with 3.5 met hours per week. And physical activity levels exceeding 14 met hours per week is associated with reduced risk for coronary heart disease and lower mortality rates. So we made this nested follow-up study inside of a Finnish public sector study, which is a huge public sector employee cohort with over 500,000 participants. And among those individuals, we found all the individuals responding to at least 2 surveys measuring physical activity. And then we made a propensity score matching with a wide control of confounding factors. And after all, we had 369 laparoscopic bariatric surgery patients, and for them, 2 theoretically identical controls. And the physical activity was measured before and after the operation. So the body mass index decreased as expected. And in the first 2 years, the physical activity increased significantly, but after that it started to decrease, and after 6 years there were no significant differences between groups, and at 9 years they had returned to level of the controls with severe obesity. The biggest change was seen here with the moderate level physical activity. It increased significantly, but again started to decrease over the years. When measuring a vigorous level physical activity, there were no significant changes, but the proportion of physically inactive, it also decreased significantly in 2 years, but then started to increase again, and see here at the 9 years, there is no difference whatsoever between the groups. So when assessing the level of obesity before surgery, it was seen that individuals with obesity class 2 increased significantly their physical activity, but it started to decrease. And for some reason, the individuals with obesity class 3 didn't have any differences between, compared to their controls. We have limitations. We have a self-reported physical activity, and there is a risk of over-reporting physical activity, but this study is completely separately made of bariatric surgery pathways, and also all the cases and controls report to the same, or answer to the same service. It has self-reported weight and height, and it leaves limited subgroups analysis. The bariatric patients could have received counseling in this physical activity, but it's not routine in Finland. And our study is made in ethnically homogeneous female-dominant occupational cohort from single welfare country, so it can't be generalized. So as a conclusion, physical activity tends to increase after bariatric surgery, especially among those with obesity class 2, but the effect is not sustainable for some reason after 4 years. The individuals with obesity class 3 did not show any changes in physical activity, although their body mass index decreased. So what prevents them? This is so interesting. We need for a long-term behavioral support to help sustain these positive changes, and promoting physical activity should be an essential component of post-bariatric care ways to support weight management and overall lifestyle improvements. So I thank you.
Thank you. Are there any questions? If not, I think we should move forward to the next presentation, and Mr. Albert Caballero will talk about the impact of MBS on the progression of chronic kidney disease.
Okay, good morning. The last one, and it's a short communication, I promise. So it's a work done by the endocrinologist department of my hospital. I'm Albert Caballero from Hospital Germans Trias in Barcelona, Spain. I don't have disclosures. So the prevalence of chronic kidney disease is about 8 to 16% worldwide. Overweight and obesity are present in the 60% of the patients with chronic kidney disease. Obesity increases the risk factors involved in kidney disease progression, like hypertension, metabolic syndrome, diabetes. Obesity is strongly related with the risk of chronic kidney disease progression and end-stage renal disease. In the Framingham Offspring study is a large cohort, including participants without pre-existing kidney disease, in the mean follow-up of 18 years. And it shows that higher BMI was associated with higher risk of developing chronic kidney disease. And the higher risk was found for diabetic nephropathy, but also a risk was found for the nephrosclerosis, glomerulonephritis, and other causes. So our objective is to describe the prevalence of chronic kidney disease in patients who have undergone bariatric surgery and compare changes in glomerular filtrate ratio and ratio albumin to creatinine according to initial stage. So it's a single-center retrospective study of 334 patients who underwent bariatric surgery between January 2021 and January 2025. Anthropometric, clinical, and renal parameters were evaluated. The longitudinal evaluation of glomerular filtration rate and ratio albumin to creatinine was analyzed using mixed effects model, adjusting for clinical covariates, and continuous variables are presented as a mean or categorical as a percentage. So these are the demographics. We have a total of 334 patients, 174 sleeves, 141 Roux-en-Y, and 19 SADIs, and we separate diabetic group, and it shows that the ratio albumin and creatinine was higher for this group. And the results was the prevalence of chronic kidney disease was 14% in total, and 15% in group of diabetic patients. The prevalence of glomerular filtrate under 60 was 7%, 7.5 in total, and 15% in diabetic patients. And the prevalence of microalbuminuria was 18% in total and 42% in diabetic patients. And this figure shows that weight loss is better for patients with a normal, with glomerular filtrate more than 60, and they lose, the weight loss was worse in the patients with glomerular filtrate under 60. So this is the categorical description of glomerular filtrate, and this graphic shows the green line and the yellow line is chronic kidney disease grade 2 and 3, and it shows that they improve their glomerular filtrate on the first 1 year and 2 years after surgery. So in a stage 4, not improve a lot, and in stage 3, we have 3 of 5 patients death before 2 years follow-up, 1 heart attack, 1 upper GI bleeding, and 1 sepsis. And this is evolution to albuminuria according to initial stage. And we can see the early stages of microalbuminuria can improve a little bit, but the severe albuminuria not improve so much. So the conclusions are that bariatric surgery may reduce the progression of chronic kidney disease, particularly in early stages, and the benefits are less consistent in advanced stage of chronic kidney disease or in cases of severe albuminuria, reinforcing the need of early intervention and the multidisciplinary approach. So thank you.
Thank you, Albert. Any questions? Yeah.
So it's a great talk. So do I understand correctly that for this green line, these patients are the mildly kidney insufficient patients, right? At 4 years, the GFR is basically the same as at the time of operation. So there's just a temporary effect, or is it related to the fact that the patients at 4 years have less muscle mass and the creatinine-based measurement is less precise?
We don't have this data, but we see improving in 1 to 3 years, but then come down again the glomerular filtrate. So we don't know why exactly.
Okay. And the second question, what's your strategy for those who need a kidney transplantation? Do you perform bariatric surgery as bridge to kidney transplant, or you try to do kidney transplant robotically to decrease the wound complications, or what is your current thinking?
We have a few cases. We have these cases that is in stage 3. We have done, I think, 2 sleeves and 1 Roux-en-Y, something like that, and 3 cases where they've been in the 2 years before transplant. So I think bariatric surgery can help them, but we have to be careful with this stage 3 chronic kidney disease.
Okay, Albert, did you perform correlations between all the patients and all the...
Between what?
Albumin, weight loss.
Yeah, well, I don't. The statistics were done by my colleagues of the endocrinology department, so I don't know exactly what kind of a statistic they do. So.
Okay, thank you. We have no time. Thank you very much, everyone, for staying here, and congratulations, because I think the presentations are excellent. Thank you very much.